Okay, it's connecting now. It's not on yet. I'll let you know when it's on.
Mhm.
Okay.
Okay. All right. Hello, everyone. Welcome to today's Facebook Live panel on heavy reading, which was a blog piece that was published in the Johns Hopkins Nursing Magazine. So starting off, we just want to recognize that June is Pride Month, so yay Pride. But often Pride is perceived as like a big party or celebration with lots of colors and fun. But we do want to recognize that it is meant to commemorate the 1969 Stonewalling Uprising that helped incite the modern LGBTQ+ rights movement. And so when talking about LGBTQI+ and racial oppression, often we forget that it can be very quiet and structural. And so these oppressive forces, are baked into the laws and institutions that benefit some groups over others. And so even in curricula, like nursing curricula today, you see some groups being unknowingly benefited over others. And so, for example, in specific to what we're going to talk about today, many nursing textbooks can present race as like a biological risk factor for disease instead of recognizing how racism, historical injustice, and social determinants of health are drivers of illness. And on the, and as well, many nursing textbooks also perpetuate stereotypes and mischaracterizations of the LGBTQI+ community, or just don't even mention them or their healthcare at all. And so that's why our working group at the Johns Hopkins School of Nursing is systematically evaluating how Masters of Science in Nursing, entry into nursing required textbooks present and rationalize the health of underrepresented racial, ethnic, and LGBTQI+ groups. And so today we've gathered a group of panelists involved in the review, both students and faculty, to go behind the scenes of the process and talk about why it matters. So let's meet our panelists today. We are all part of Work Group 2, Assessing Teaching and Learning Processes and Practices of the Johns Hopkins School of Nursing's Committee on Teaching and Learning as a Pathway to Diversity, Equity, Inclusion. My name is Angie Dang. I'm a recently graduated Masters of Science in Nursing student from Hopkins, and I was a student reviewer on the LGBTQI+ team. We also have with us Meredith Klepper, who is a second-year PhD student and who was also a reviewer with me on the LGBTQI+ team. And then we have Carissa Lawrence, who was a second-year PhD student reviewer on the same LGBTQI+ team. And then Leah Marino, who is a third-year PhD student and was a reviewer on the race and ethnicity team. And then we have Ruthalma Turkson-Okran, who is a postdoctoral research fellow and was a reviewer on the race and ethnicity team. And then Dr. Mona Chattel, who is the exiting associate dean for faculty development at Hopkins and was a faculty member for both teams. And finally, we have Dr. Rita DeOst, who is the associate dean of teaching and learning and the chair of the Committee on Teaching and Learning as a Pathway to Diversity, Equity, Inclusion. All right, okay, so after that big mouthful, we can start to go into our discussion questions. So for the group, and feel free anyone to jump in, and please again give a quick introduction for your name and pronouns when you answer. Can you talk about why this review came to be or how it came to be?
Well, either I or maybe Rita, I don't know if you want to take this, but Rita or Dr. Doust was or is the co-chair of the larger committee. I don't know, Rita, do you want to give a
Yeah, so certainly in December of, this is 2019 maybe, what we wanted to really do as a school is to really look at the structural barriers that we have and the biases in the way that we not only portray different groups, but also the student learning experience. And so what we wanted to do is to take a leadership role and to move to what I'm going to call is DEI 2.0, and to really looking at how teaching and learning, our practices, our assessment, our materials are really products of reproduction of how we continue to either marginalize groups, how we continue to present groups, and to really take a different approach. This was internal, external stakeholders, and we really came to about 3 major areas. How do we assess and address our biases across different groups? Both looking at as much as the diversity, but as well as the inclusion of not just any one group. And then the second one was looking at our teaching and learning practices and what are those practices, and then what are the resources we can provide. And then last is, certainly not least, is how do we disseminate this knowledge in this initiative? And you're looking at one of the work groups.
Yes, and again, I'm Mona Chattel, Associate Dean for Faculty Development and chair or co-chair of Work Group 2 that undertook this project, or these projects, sorry. Dr. Cecilia Tamori is the other co-chair, and Dr. Lucine Francis, who couldn't be with us today, but they were instrumental in helping facilitate the group and the projects. But we couldn't have done it without our student leaders, Angie, Meredith, Ruth Alma, Leah, and Sarah, and many others who are not with us today. And really the work, of the larger committee that Rita spoke of, started maybe almost 2 years ago, was it Rita? And then our group, and Leah, maybe you want to talk about, you and Ruth Alma, you started this well before Work Group 2 came into existence. So we had the benefit of really joining with your already ongoing project, and really, I think we helped each other to help it move along. So I don't know, do you want to talk about that? And
Yeah,
Dr. Sarah Zanton also.
Yes, I guess I could go, and then Leah, please fill in where, or even correct me where I missed the mark. But we started this project, I guess it started as one of our projects for the discrimination work group, which was headed by Dr. Sarah Zanton. And we had always had this on the books as something to do. And we, I guess, started the groundwork at that time, but it didn't take until I guess this spring when we actually were able to secure the textbooks that we needed to review and started working on the project. And this is specifically for the race and ethnicity group. And while we're doing that, we found out that another group was also doing it for the LGBTQI plus textbooks. And so we joined forces and had several joint meetings just to try to make it essentially parallel. And if there were things that were strengths in ours, how could it be strengthened in the other group and vice versa? Leah, do you have anything to add to that?
I was just going to add one more shout out to Dr. Parker at the School of Public Health, because she was also co-leading the discrimination writing group. And I believe it was her or other members of the group that really were the ones that thought of this systematic review of how race is depicted in nursing textbooks. So they were so generous and kind to let us take over that review to continue the work.
Thank you.
Okay, great.
We want to say, yeah, it started with race and ethnicity, but then quickly we realized that we really needed to do more. So that's when we started the other subgroup with the LGBTQ plus. So I don't know, Angie, Meredith, if you want to talk about how that started.
Yeah, so Meredith and I are both student leaders, or I was, and now that I've graduated, we were student leaders of the LGBTQI plus health initiative, which has the faculty advisor of Dr. Kelly Bauer at the School of Nursing. And so, yeah, I remember we were approached, I think, by Work Group 2 at the time saying, hey, like we want to create 2 parallel searches of looking both at race, ethnicity, and then also at LGBTQI plus identities and how they're represented in textbooks. And so we were like, this is a great opportunity to take a look. And personally, like as someone who just graduated from the program that the textbooks are required by, like I did, have my own personal issues with the textbooks. And I heard from my classmates, particularly about how race is depicted, because it's brought up more often in textbooks usually than LGBTQI plus identities. So I thought this was a great project to look into. I don't know if you had anything else to add, Meredith.
Yeah, no, I think that is a great description. You were part of the project before me, so I'm so glad you're here. I joined not quite a year ago, last summer, and I appreciate your perspective, Angie, as someone who's been through the program. So you had some familiarity with the textbooks. I had not, but quickly saw some of the issues that you're describing that we'll get into today, of either missing information or inaccurate information. And so I'm so glad we have the opportunity to examine that. And then Carissa has joined us a little more recently, not to put you on the spot, but I don't know if you have anything to add since you've joined.
Not specifically. As a second year student, kind of networking with Meredith, and my research interest being in LGBTQI health equity, Meredith said, Chris, I'm working on this amazing project and I think you should be a part of it. And once I realized what it was, I was like, absolutely, we have to do this. I have to do this. So I joined a little later in the last few months, but I was able to go through some of the textbooks and pull data from that. So really eye-opening. And as a provider, in my own history of using textbooks to train, it was not surprising. And I'm glad that we are able to really work on that now.
Great. So now that we've talked more about the background. Oh, Rita, were you going to say something?
Yeah, I was just going to add that just prior to the textbook, the School of Nursing actually started looking at image libraries in the presentations, because we found them what is either typically used or even what is commercially available very limited. So we hired a digital archivist, a librarian, and really catalog things. But to this day, it is a very difficult component, whether it's a textbook or whether images that you're using in presentations, to be able to reflect the diversity that we have in society, whether it is the health professional, whether it is the patient, or in whatever venue that is. So the textbook review was critically important, and also adding and trying to coordinate some of these, so that we were excited about the work.
Rita, that's a really good point. I mean, even those of us who I don't think I think I'm pretty aware of this, but I'm writing a book on social media for healthcare professionals, and one of the reviewers commented that we needed to have more diversity, and so we totally took that feedback and are changing some of our examples. And so we can all do better. And this project is really showing us. I mean, we knew where their problems were. Now we really have done a deep dive into it. And no, Angie, I know you're following the questions. It seems like people really want to know, what we found and what we're going to do about it. I don't know if you want to help us get there.
Yeah, I think before we get into the findings, I just wanted to ask if anyone wants to talk about our general approach or methods to actually get to the findings first.
I think
All
that's a
these
good
PhD
idea.
students. Come
Go
on,
ahead.
methods.
I can quickly just talk about the scope of the review that looked at how race and ethnicity were depicted in the textbooks. So our scope was limited. There's a lot of different things we could have looked at and things that are really important, but just for feasibility and to be able to complete the project, we focused on how racial and ethnic disparities in health outcomes are presented, what kind of context, if any, is provided. So we kind of qualified the context that was given, and then are disparity statistics and context cited. So are the references provided when they do give context or when they do provide some sort of statistic? So that was the specific scope of our project. We had 131 racial and ethnic terms that we looked at. Yeah, and I think that's it. Ruth Alma, do you have anything else to add?
Yeah, so I would say that we also try to do it as synchronous or, virtually as we could. So what we did was we created, I guess, a platform used probably Excel spreadsheets to just keep track of everything. And we also had, I guess, other group members double check what we did. If we disagreed on something, came to a consensus, and we had some criteria that we also used to try to form that consensus. And so I thought it was a pretty systematic and I guess intense way of looking at these things too. And we also did try to meet with the other group, with Angie, with the LGBTQI plus group, and also to see whether we could also, for example, learn some things from what they did also, and they us.
Yeah, you've all been a huge help to us. We had a pretty similar approach. We came up with a list of terms as a team, mostly terms that we felt were affirming and important that we would hope to see in nursing textbooks. Some terms that are either outdated or really generally not preferred by the respective communities. We also included to see if there were problematic uses of language coming up that we might not otherwise catch. And then we divided textbooks among our team members. And as we reviewed, if we found new terms, we did add those and rerun the searches and came up with quite a long list of terms. And then Angie, I don't know if you want to talk about our preliminary sort of qualitative findings, because you were the one to present them at a conference recently.
Yeah, thank you, Meredith. Yeah, so for our preliminary qualitative analysis, before we do a deeper dive into it, we noticed a lot of common themes when the terms did come up. And I don't want to get into the findings too much, but because that's the next section. But overall, we saw a lot of like omission or erasure of LGBTQI plus identities, and a lot of like othering like LGBTQI plus people by presenting like straight or heterosexual or cisgender people as kind of like the norm or like a normal patient, whereas LGBTQI plus patients were seen as more of like a special population or a special category, that they kind of almost implicitly implied that providers wouldn't really come upon them frequently. So it's like, oh, because you're not going to come upon them frequently, you shouldn't talk about it. But you do need to talk about patients, even if they are in the minority. And yeah, and just like potentially even harmful claims about the community, which we can get into more specifically. Did anyone else want to speak more to the overall process?
I should just shout out Dr. Catherine Ling at the School of Nursing. She has been involved with our LGBTQI health initiative, and she graciously stepped in to help us do this first pass qualitative analysis so that we could try to disseminate some preliminary findings.
Yes, thank you.
And our pre-licensure honor students, right? Adam Abbott and Cassidy Griffith. Yeah, thank you, Meredith.
Yeah. All right, so then now when discussing the findings, did people, the reviewers of the group, so Ruth Alma, Leah, Meredith, Chris, and I, what kinds of language or gaps in instruction did you notice, or potentially what were some positive portrayals that you may have also noticed?
So I think Leah started I guess mentioned some of them, and a lot of them is, specifically for the race and ethnicity group. So what we're seeing is that, for example, if you take cardiovascular disease, for example, say that Black persons have higher rates of hypertension, for example. But then when you what we did was that there was not necessarily any context to that. So what we were expecting is the why is this the case, you know, but then the conversation or, you know, the discourse in the textbooks just ended there. And also what we didn't see was acknowledgement of other, you know, psychosocial factors that may be contributing to that. So there was not a lot of that discussion, and that's something that we felt was important. Not just to say, okay, there's a difference, there is a disparity, and then just throw it out there for people to say, okay, you know, to I guess keep on, I guess perpetuating that type of knowledge or that type of information without knowing the backstory. That was one of the most salient ones for us. Leah, you can go ahead and speak to other ones that we also found.
Thank you, Ruth Alma. Yes, those are another point I just want to bring up quickly is we're still doing the review. We just have 3 books left out of 14. But we've been seeing the same things over and over and over again. We've reached, I guess, what you can say, data saturation. We keep seeing the same thing. So yeah, the big one, like Ruth Alma said, is this listing of race as a risk factor with no context provided. So, you know, we know race is not a risk factor and it should not be used as a proxy for genetics. Racism is a risk factor, and that's not discussed in any of the books. Also, omissions of important historical context for racial disparities. So very few books, if any, talked about slavery or redlining or racism, colonialism, like those things were not included. And then using white as the standard reference when listing like epidemiologic statistics. We see a lot of that. I think those were the big ones.
Yeah, yes, and I just wanted to also add that, you know, when they also cited a difference, right? When they said there was a difference, there was usually no citation or no kind of information, research, or otherwise to back that up. And we thought that was important because, you know, as people who are in academia, we want to know where exactly are you getting this information from? Can we use that information as a source? Is that a reliable source? And you know, just questions like that. And I thought that, you know, just having that would have been helpful, but that was unfortunately, you know, severely lacking.
And I just want to add to that because in doing one of the textbooks that I searched for the LGBTQI team was a psych textbook. And that's a very heavy textbook. The history behind psychiatric care and other individuals, non-heteronormative as defined, is pretty intense. So I had a lot of self-care days. But in piggybacking off of that, there were a lot of statements that were made with no citation. So nowhere for me to go and say, okay, where did this information come from? Which made it seem like these were just kind of random statements. For example, things like same gender would fall under pedophilic disorders. Homosexuality falling under pedophilic disorders. The two aren't necessarily related at all, right? They're not, they're separate things, but that phrase came up and we write down what the context is, but I had no citation, right? Homosexual under an eating disorder. In the psych book, it just seemed like there were a lot of terms that were pathologically associated with same gender, same sex, but there wasn't any context for healthy relationships, and this is what different relationships look like, right? This is what different family units look like. They did focus a lot on gender dysphoria, but there needed to be more work, right? More inclusivity positively. And with the lack of citations for a lot of the negative things, it made it really difficult to understand the true context of where this was coming from, other than discrimination, bias, etc.
Thanks so much for sharing that, Carissa. Yeah, I definitely saw a lot of the things that you describe and a lot of the things the race and ethnicity team is describing in the books that I searched. There were some bright spots. The gerontology book really had a holistic view about sexuality and even talked about heterosexism. I was like blown away. It was really great in parts. And then another thing we noticed, I don't know if race and ethnicity, if you've seen this, but quite often there's like a distinct kind of shift. Like you can tell either different people wrote it or I don't know what happened, but there'll be something quite affirming and saying, oh, you should, always consult experts in this area. And then boom, later on the same page, maybe using a term that is really a microaggression. So that's something that we've been looking at in terms of reaching out to authors or editors. I don't want to get too far ahead, but yeah, looking at that sort of discordant language and like changing of voice between authors has been really interesting. And then for our search, omission is a really big problem. Like LGBTQI plus people just aren't mentioned in a lot of health promotion and positive health areas especially, or they're siloed into usually sexual health specifically, maybe adolescent health. But that does send a really strong message that like you could be experimenting as a teenager, but then once you're an adult, this never comes up again. And we know that that's not accurate.
Yeah, and I guess maybe going back to what you were saying about noticing that difference in voice. Yes, that was also some, something that we did see, I guess for example, you're talking about in some places you talk about, Black people, and then other places it's Blacks. And, so that is just not, that's not something that you want to see. And I guess, again, jumping ahead, that would be nice for, editors and people who are, just, overseeing this book publications to just make sure that things like that are in the same voice that is consistent throughout and respectful, So I don't know whether anyone else has something to add to that.
Yeah, that also brings to mind to me how textbook language can be very gendered and specifically binary gendered. Like it'll say like, when the patient comes in, ask him/her instead of just saying ask them, or, creating whole chapters on men's health and women's health. And then maybe at the very bottom being like, oh, by the way, trans people are a thing, but then not really explaining, more of the nuance of like, if you have a trans patient come in, how does their care change compared to like a cisgender person? And sometimes it wouldn't really change much because of the advent of gender affirmation surgery and hormone therapy and things like that. And on the topic of trans patients, we received a question that said, I have done some recent collaboration with a transgender patient on the push for asking a patient their pronouns. Have you seen this being addressed in textbooks? Also, we had an unexpected response that there is no guidance on verbiage for healthcare providers to use when a patient is not comfortable sharing their pronouns. Do you have any thoughts? I know this is more probably aimed towards Meredith, Carissa, and I, but do you guys want to go first, or?
I did not see any mention, correct me if I'm wrong, Angie, or if any of yours or Carissa. I don't believe in the current curriculum there's any textbooks that mention asking a patient their pronouns, what to do if patients say, I don't feel comfortable. I will say on a personal note, things like that make a world of difference. I have just recently found gender affirming caregivers, and just not having certain things assumed makes so much space, and it frankly makes me less resistant to going. And I
Yeah, I
know,
can't.
oh,
Sorry.
sorry. Go
No,
ahead.
no, no, you
I was gonna
finish.
say, I know that relates to Carissa's research interests. So I was thinking of her, but go ahead, Angie.
Yeah, I will say, I believe one or two of the textbooks I looked through, which did have a little bit more LGBTQI plus content, just kind of briefly mentioning and asking pronouns, but sometimes they'll say like preferred pronouns when they should just say pronouns, because preference makes it seem like it's optional. But then it's strange because they'll mention that and say like, this is important, but then for the rest of the textbook, things will be very heavily gendered, or they'll assume a lot of things from their patients.
I do recall at least one book that talked about, oh, you should assess for this if appropriate, which made me feel like,
Yeah,
how
that's
are
sketchy.
you basing that decision?
Yeah, yeah.
If somebody looks overtly gender
Yeah.
nonconforming, if you suspect they're trans, if you see in their chart that they're trans, I wasn't sure what they were getting at, but I don't think it was the best way to
Yeah.
approach.
Yeah, so I think the only thing that I can think about specifically in the psych book that I did was sexuality was very broad. And so they did reference, asking questions and pronouns, preferred pronouns. But in going and touching base on verbiage that's for providers, that is an interesting question because I feel a lot of times when we put a lot of emphasis on this is the script, we leave little room for creativity and individualization, right? So if a patient isn't comfortable giving pronouns for whatever reasons, it could be they're still figuring it out. They don't want to share, they just don't feel like doing it. That is okay. We as providers have to give patients the space to say, you don't want to do this. Well, then how would you like me to address you today? How can I call you so that I address you appropriately? And the next time you see that patient, if you see them again, it may be something different. And as providers, we need to be flexible in that, because the more comfortable a patient feels in coming to us for care, and this is me talking as a nurse practitioner, as a certified nurse midwife, the more comfortable patients feel, the more likely they are to come in for routine care and health maintenance and checking in. And you can make sure you have all these factors, that their holistic self is being taken care of. So that little space of respect, even if they don't want to give their pronouns, means something. We can't just take it upon ourselves to pick an answer, but just ask them, how would they like to be addressed then for this visit, just for this moment, and giving them the space to do so.
Thanks so much, Carissa. And I'll put in a quick plug for anybody who is watching and wondering how to handle this as a provider, as a nursing student going to be entering the workforce. Introducing yourself with your pronouns is a great way to normalize it. And then you can, ask, but if people are uncomfortable, then the ball's in their court. But that is a really helpful way to make space.
Thanks, Meredith. That's a good tip. And I know that, and I guess maybe correct me if I'm wrong, that some students had also done I guess a project talking about how to approach some of these things in, I mean, not necessarily the same thing, but in terms of I guess taking a history and things like that, just some language about that. And I know it was on like the website for a while. I'm not sure where that is, but that was one of I guess our former members, Athena, also did some work in that area. And so I was thinking that maybe that could be a good resource also for people.
Yeah, I definitely think so the thing about even some of those terms, we're constantly changing what's acceptable, what's not, like that's constantly being updated. So a reservoir of sorts of information that's constantly updated can give providers some basic information that can then be tailored to, you know, whatever a patient needs. So some framework for language in that case, but then not sticking, like saying, this is exactly what I'm supposed to say, so I'm only gonna say this, right? But absolutely, Ruth, I think that that would be amazing.
I just want to pick up a little bit on that because having worked with Athena in the work that was done before, and then we go to integrating curriculum. And here's what I found is folks need more than resources, which is more a little bit of how to. Because the resources sometimes not only will they change, but they will not always be used. And so sometimes, and this, by the way, is regardless of how you identify or whatever group you're in, that it does not mean it was equally distributed. When I look at who was assigned to develop, there was difficulty in trying to find a comfortable space to do that and not be overwhelmed by the component. And so I find that as we want to select materials to use, we might have to do a little bit more. And what I'm going to say is not even coach, but it's really partnering and collaborating on how to do it. And that will work a little bit better. As I was listening to many of the comments about the textbook, there are two types of textbooks, but the big tomes, I call them, and especially in pre-licensure programs, are usually edited. So there are chapter editors. And so you were talking about the change in voice, the change in descriptions and things like that. Anyone who has written a book, I'm going through a book right now, I have a copy editor. The copy editors should be, so let's not just look at the authors. Let's look at the publishers. A copy editor should be picking up the citation, the language, the wording. The rights editor should be picking up and asking, and then the fees. The fees that we're having to pay just to have someone depicted in the way that shows our diversity are additional fees. So one of the pieces is we look at these textbooks, we'll probably find more variation and ones that are done as editors, and then they're different chapter editors. But I would also advocate that we need to be putting pressure, or not pressure, but advocating with the publishers on what else copy editors, rights editors, and fees personnel should be doing.
So Dr. Diaz, I would say then that we need a broader, inclusive membership of people who are writing the chapters, editing the chapters, publishing the chapters. If I'm paying fees for a chapter, I need people representing the communities that we are talking about, because otherwise we're just making assumptions. So I think part of that work and even that language, like you said, yes, we have this reservoir of resources with all the terms, but how often is that going to get used, right? But having people in these communities living these things who can identify with these things or working in these communities really be the people writing these stories, shaping that narrative. I think in my head, I've already pictured like someone writing this chapter on healthcare and how much different that might look, right? So I think in response to that, absolutely, we talk a lot about inclusivity. We just need to start doing it. We need to actually include people in it.
And actually pushing back a little bit on the publishers. And so I think that's important. And you're looking at textbooks and there are other learning products. So one of my students created a program on chronic pain management and alternative therapies using an unnamed software animation and to pay extra to have the the avatar be someone of color. So the basis is a white avatar and anything else is an additional fee.
I'm disturbed. I'm just gonna leave that there. I am bothered.
We should be outraged.
Yeah. And I guess not to just move on from there. I just wanted us to just revisit what I believe it was it Angie or Meredith who said that, talked about, oh no, Meredith, that was you who was talking about saying your pronouns first. We did have, I guess I just want to shout out one of our viewers who said that you should also use their name if they don't feel comfortable with saying what their pronoun is.
Absolutely. Pronouns are not required, right? It's kind of a little shortcut in language, but we can just use the patient's name if that's what they prefer. Absolutely.
Yes. Oh, sorry, were you gonna say something else, Meredith?
I just saw that Carissa might be saying something, but you're on mute. But maybe you meant to be.
I meant to be on mute. I was just saying exactly. How do you want to be identified? What can I call you? Yeah.
Yeah, and when speaking with other providers about a patient, you could always just say the patient instead of like enforcing a pronoun on them.
Keeping it neutral.
Mhm. Yeah, and this goes into even like, charting and documentation used in offices, or when you fill out intake forms, like there should be gender neutral language and a diversity of options, or not even asking patients for certain information if it's not pertinent to their healthcare.
Mhm.
Yeah.
And I also want to point out that this is quite a shift from the way many of us grew up and what was normal, right? So it's going to take time. You may make a mistake, apologize, correct it, right? You may make a mistake, you won't get it all perfect, but it's the conscious effort that I think makes a difference. Like actually trying to change the way you think, or how we think, I should say, change how we think so that we can better have that neutral language that makes no assumptions and really leave space for people to be. So be gentle with yourselves too in this journey.
It takes practice, there's no magic to it. It really just takes practice. And Carissa, as you said, if you make a mistake, I recommend a growth mindset. Tell yourself, I noticed I made a mistake, especially if you notice yourself. If somebody else points it out to you, they respect you enough to think that you'll be able to handle a correction, and they think you can do better. For me, if I correct somebody, it's because I put myself in a vulnerable position to do that. So I really try to take it as a compliment when someone corrects me. Say thank you, so sorry, correct yourself, move on. Don't over apologize. That makes people uncomfortable. Correct, apologize quickly if you feel like you wronged them, and then move on.
Case in point, I was texting you all, Meredith, I was texting you all yesterday, and I was like, is it okay to say you all? Like, I can't say, because they, them pronouns, it fits in the English language only in certain like tenses. And so I was like, can I say y'all, you all? And y'all said yes, right? Just
like, fine with me.
asking.
But you asked, maybe some
right.
people wouldn't feel comfortable. Yeah. Yeah, we could get on a whole tangent about you guys, which is not gender neutral, but we treat it as it is.
I apologize. I actually said it earlier. I realized.
I say it too because I'm from New England and we say it a lot. I try to be conscious of it.
Yeah, it's common in California too, but it is fair. That's why I enjoyed going to college in the South, because y'all was used all the time. But yeah, anyways, so now that we've talked a bit more about the findings and our takeaways from the data and the analyses and the data that's to come. What do our next steps look like as a group? What would be involved in that?
So I guess I can speak, again, speaking to the race ethnicity group. So the first thing that we're looking to do is to, clean up, finish our analyses. And then we do want to put it out there. We do believe that it should be disseminated, so publishing that. But also we do want to reach out to publishers or editors of these texts and say, this is what we found. These are the recommendations that we do have for improvement for the future, and hope that they'll be willing to talk to us and make those changes for, I guess, for the better. Does anyone have anything to add? Is that the same thing? Go ahead, Leah.
I was just going to add one quick thing. And we also realize having like real changes in the textbooks is going to probably take a really long time. Even though we're optimistic, it's not going to be something that's quick. So I'm just a student. I'm not faculty, but I think there are initiatives that are taking our recommendations and our findings and trying to incorporate these things and make changes in the curriculum. I know as soon as we started showing our findings, a disclaimer was placed on the syllabi to let students know, we know these textbooks, there are problems with some of the course materials. And we're working on trying to make changes. And this is a process, we're aware of and that we're working on. Yeah, I think probably Dr. Chattel and Dr. Dowse can speak more to this, but I do think there are changes that are being made at the school now.
Definitely. We talked a little bit about the image collection. The curriculum committees are actually looking over teaching practices and also in the course revisions and other components. The other piece, as I would say, is that there is an awakening. So first of all, I would ask the question, why is there perhaps an over-reliance on textbooks, which may not even be the most current or best evidence, and other kind of components? The other component that I would say that we're doing quite a bit is as a faculty group and student, we've had one consultation. And as a group looking at, first of all, microaggression, looking at how we look at things, how we address, what are the methods we use, and then how do we, teaching methods, and what do we do differently as a result of it? The next piece we're working on is how do we start looking at health equity, leadership, and some of the structural racism. But one component that does come up quietly to me sometimes is depending on where you are in the country, the racial ethnic varies. And the group that I will say that I will hear the most about are the ones who are invisible, and that's the Indigenous American. They're not even counted because, well, those numbers are low. But we will look at race. We might look at Hispanic. We might look as if it's all one group and losing nuances. So I think what we're starting to do is take a deeper dive. We have statements now about what we're trying to do. We're going to look at our course evaluation and saying, in that course evaluation, I'm also being reminded of my to-do list, but which is when we ask the item about, first of all, the student experience, is it sensitive enough? Are we picking up in the clinical learning environment, which we have not touched upon right now? Group projects also are a big one. But then the second question is the teaching strategy. So whether it's the books, the presentation, multimedia, simulation, I ask folks to look in your simulation, your lab areas, and ask me if your mannequins are all white, if they're all, female, if they're this, and to look at those. So we're starting to look at those things. We've added questions and faculty evaluations about what we're doing, and also in other components. So in a nutshell, Mona, you probably have a few more that you might want to add.
Yeah, certainly. There are lots of faculty development training opportunities, and many of those are planned. And Rita, you did mention consultation and curriculum committee. But what has happened since we've been presenting the findings to the curriculum committees is that small groups of faculty, like course teams, have been coming together and meeting with some of our student leaders and really getting help on their individual courses. Like, can you help me really make this better? So really, I think faculty in general are open and willing and really want to do better. They just need better tools. And certainly, to Carissa's point earlier, we need a more diverse faculty. We are more diverse than many faculties in schools and universities and colleges and schools of nursing, but we are nowhere near where we need to be. And that would make a huge difference for us.
Yeah, and I can provide a couple concrete examples of how current faculty have been receptive to our findings and our recommendations. So, for example, last year we noticed some particularly harmful language against transgender people in one of the research textbooks. And so we reached out to the research faculty and they were very receptive. And so since the class had already begun, something like a resolution that they tried was to provide a disclaimer in the course like bulletin board, and to also put a disclaimer in future syllabi, like discussing like, yes, we use this textbook because it has important information about research and like methodology and things like that, but at the same time it does include like a short passage that is harmful, and so for students to be aware of that. And then also recently, Dr. Joanne Silbert-Flagg actually came to us looking for recommendations because she is trying to revise the maternal and child health textbook, which is used both in the childbearing and pediatric courses. And so we created quite a long list of recommendations for changes in the language and just gave it directly to her to use. And even with the psychiatric textbook, like Carissa said before, it does have a lot of problematic language, and the psych instructors are aware and they want, to find a better text. It's just that right now in the world of psychiatric nursing textbooks, there aren't that many better options. So, it's kind of a balance, but we do want to keep pushing for change and not just be complacent with what's available.
I think Leah may have pointed this out earlier when she said, things will take time. And, but I think, I think I said it earlier, was we just have to start, right? It'll take time, but we just have to start. So I am honored to have been on this team where it was already starting, the work was already starting, and joining in and being able to continue in that has been amazing. And I'm hopeful for where this goes, and as it continues to grow and shape every year. It won't be just one change, it'll be many changes over time. And I think I'm hopeful for the generations to come that they will see a much different curriculum when they enroll in schools.
Yeah, and in speaking about curricular change, Meredith, do you want to talk more about the LGBTQ Health Initiative's TALT measure?
Sure. So Athena Sherman, Dr. Athena Sherman's name was mentioned earlier. So they graduated from the PhD program here at Hopkins 2 years ago, I believe. They're a mentor of mine, and they began the LGBTQ Health Initiative with other students and faculty excuse me, and they've remained on as a consultant. So this year we developed a tool, and it's still just finished pilot testing. We've been validating it, just pilot tested it at Hopkins and at Emory, where Dr. Sherman is on faculty now. And it's a way for faculty to evaluate their courses and then can be looked across the curriculum. So it's not intended for each course to check every single box, because we don't think that's realistic, but rather we can look across courses and see, is there comprehensive and accurate information being presented in these courses? We didn't really touch on yet when we were talking about results, but there's just some things that are inaccurate, you know, conflation of sexuality and gender, terms that I mean, this is my area of interest. And I was like, what is that? Like bisexual gender orientation or something came up in one of the books. And I was like, I was like, I feel like my identities are like in there somewhere, but that's not how these things come together. And I imagine you may have seen similar conflation of race and ethnicity in the textbooks that when you reviewed. So yeah, making sure that things are being accurately represented and having inclusion of LGBTQI plus content.
Yeah, thank you. So we just want to touch on that. Not only do we have this textbook review project, but there are many other initiatives as well, both within the Hopkins School of Nursing and, you know, at other schools of nursing that are trying to push for greater diversity, equity, and inclusion. I believe we got a comment as well that said, will this group look at healthcare charting systems such as Epic, which is used at Hopkins Hospital? When students enter their clinical component, would it be beneficial to review the charting tools used at the clinical sites? I can say that I know that on Epic, because my partner is transgender and they use they them pronouns, patients can enter their pronouns when they go on to their MyChart account, which is linked with Epic. And so then the provider can see what their pronouns are. And I even have my pronouns in, even though I identify as cisgender. And you can have your, you know, the name that you would like to be called. And you can even put identity terms. Like for me, I have bisexual up there. And then for other people I know, you can even choose like non-binary or genderqueer.
Yeah, Angie, thanks for pointing that out. I actually see a Hopkins provider for routine care. And when I went yesterday, I hadn't been for a couple years. I went for a visit and she said, oh, did you identify as non-binary the last time you came in? I was like, no, that's recent, relatively recent. And she was like, okay, I wanted to make sure because I have something else. And I wanted to, like, she noticed, which was really just so appreciated. So it's kind of like we were talking about with, you know, you can have the resources available, but you also need to be paying attention and sort of seeking those out. So we need to help support people to know where to look, to understand why it's important to value these things, rather than just having this, you know, you need both. You need the structural, and then you need people to understand how to plug in to the structure, I think.
Meredith, let me ask you a question. Why do we wait until we're in the hospital systems or the outpatients? Why don't we look at our own laboratory settings and start looking at how we model and start to do those?
Absolutely.
Yeah. I say to folks, by the time you wait till somebody's in the practice setting, that's tougher than if we start really laying that foundation, and especially things that we have control over, more control. Let's start making the changes there.
Absolutely.
Yeah. Krista, you wanted to say something?
Oh, no, sorry. I was just going to say a quick thing about Epic. So like, as we're wrapping up, one of the things I would love to see is I wish that a lot of these electronic medical softwares had like basic framework, because a lot of what we see in some of them, you pay additional to build out. So EPIC at Hopkins looks very different for EPIC at another institution. It's not just EPIC, right? So I know from my midwifery practice, when we did our integrations and our clinicals, we were at different sites that used all sorts of things. So some systems had things, other systems didn't. And I think having like, this is your basic framework that includes these things as basic forms of care, instead of having it be you pay additional to add on what they think are novelty things, I think would also help in regards to that. So just pointing out that with EPIC, it can be hit or miss depending on your practice site and what they've paid for.
I totally agree. And again, as we're wrapping up, I think the same also goes with, persons from, whatever, I guess, race, ethnic background also. Some people, I guess it goes back and forth as to saying, okay, being sensitive to the fact that, there are immigrants, there are people who identify different from what they may look like. And so having all these things also being included structurally, would address that part of it. And so that's just what I kind of want to end with. I know we're like running out of time.
I have one last comment because we're talking about how to really start a transformation. And at least the American Association of College of Nursing has come out now with the new revised essentials, the standards for professional nursing practice, which are competency-based. Social determinants of health, DEI, equity are concepts that are going to be integrated. But there is an ability now for all nursing schools to really make a difference by really tracking that threading and looking at the competencies. And I know, Leah, that's one of the pieces you're helping us with in a course, but we have an opportunity here in nursing. And I would say, let's not let a good crisis go to waste here if we're going to be transforming anyway.
Thank you for that, Rita. Yeah, it's been a minute after you're supposed to end now. Is there anything else anyone would like to mention before we have to go? Well, I personally just want to thank everyone for being here and for contributing so much, rich conversation on this topic. And I'm really glad that this project has made it this far. And it was, very enriching from my experience as an MSN student at Hopkins.
Thank you, Angie, and thanks for moderating today.
Yes, and I also want to, and I want to thank the School of Nursing and for just giving us this platform just to spread the word and to reach out to a lot of people. So thank you.
Thank you all.
All right.
Bye.
Thank you, everyone.
All right.
Thank you. Bye.